Let's start discussion. So I'd start with requesting Mehmet to say a few words, and then we move on to our all the panelists.
Yeah. It seems that it is still a challenging disease, very unique portion of the human anatomy, and it is not just covering the brainstem and spinal cord, but also having big rotational movements. And we know that we are having good results with the decompression only. But Atul still insists to make fixations. Probably our speakers may make some comments on that issue, especially Jörg and Juan and Pravin. Pravin has already did his task. Yeah, this is what I want to say.
Okay. I've had a lot of discussions with Atul in the past on this topic, and I acknowledge his results as he presents them. On the other hand, I must say that I've been treating Chiari malformations for about 30 years now. And apart from patients where the Chiari was associated with basilar invagination, we did decompressions, opening the dura, opening the arachnoid, and performing a duroplasty. And doing so, we had immediate postoperative improvements in around 80% of the patients. And we followed up these patients for 10, 15, 20 years. And we found with Kaplan-Meier statistics that around 90% of the patients are more than satisfied with the surgical result for 20 years and more. So if decompression would be such a disaster for Chiari 1 patients, the results shouldn't have turned out like this. So there clearly is some disagreement at this point, in that decompression of Chiari 1 very well may serve the patient and may actually provide them a normal life, specifically if you do it in time in children and in young adults. And they have very, very nice results. On the other hand, we have to acknowledge that craniocervical joints have to be looked at very carefully, and that we have to analyze in each and every patient whether there's an abnormality there, and if there is, then fixation may be more than advisable and may actually be necessary. But it's not correct to say that, in my mind, that every Chiari patient has to be stabilized.
And Jose, your turn, please.
Yeah, well, I agree with Dr. Klekamp. There is no room for stabilization in all cases of Chiari malformation. In adult patients with classical Chiari 1 malformation, the decompression is enough to have a good outcome. I think, of course, in cases of basilar invagination with malformation, we can speak a lot about stabilization, but in classical patients with Chiari 1, no. I have patients operated since 20 years ago that are in good shape. Also, some of my patients are playing rugby, so probably there is no problem, no instability. I agree with Dr. Klekamp, and I disagree with Dr. Boer.
Yeah, I think I must also share our experience in the last 25 years. And since Atul has been talking about it, we routinely now do looking for instability x-rays. And unfortunately, we haven't found many patients. I think in last 15 years, we have had only 3 patients in which we fused, and we thought there was instability. Rest of them, for whatever reason, don't turn up on our door. So I'm not sure, but as far as we can see at the moment, consensus is still there that decompression is probably the way forward. Let's hear from Abida since as she's here as well.
Yeah, Professor Salmani, I'll speak on behalf of Sir. So we have done a huge amount of cases now, and we are fixing. There have been series like maybe when I was a resident, we were doing foramen magnum decompressions. We are fixing those patients as well when they come back, and we are seeing the results. This remains a mystery. We are trying to analyze it in our own way as to why it is happening. But when we do open the joints, they are tremendously unstable. So that is definitely an indicator for us when we are operating that this is unstable. Like I've done a child about a week back, 2 years old, who was not walking, and I have fixed it without any kind of decompression. And within 10 days, the child has started walking. I mean, the patient was walking before, he developed some issues and then stopped walking, and now he started walking again. So the results, the clinical results are really dramatic. And as Sir says, you have to see it to believe it. And we'll come out with some reason of why it is happening for sure. But yes, instability is the cause for Chiari formation.
Sure. Oscar, would you like to share your wisdom as well? Can we? Okay, I've just unmuted you. Please unmute.
Hi. Sorry, guys. I was in a flight. I could not join earlier. I mean, I think when we talk about Chiari malformation, probably we are talking about different patients when we are talking about European patients or Brazilian patients or Indian patients. So, and grades of instability might be different on those patients. I really agree with Klekamp. That's my experience with our Portuguese patients here. And we try to keep it as simple as possible, mainly sometimes doing most of the times just osteoligamental decompression, and it goes really well. Obviously, you have to go wide, so CSF can flow not only posteriorly but also laterally. I quite like the coronal MRIs to assess that. But I can admit that patients from India, from Brazil, there are elements of instability, and in this sense, it can make sense. It makes sense what Atul says. So I'm not sure we are talking about really the same patients. Thank you, Salman.
Thank you, Oscar. Praveen, would you like to add something?
Now, the patient population is same. We are in the same country, and in fact, I have tried fixing the C1 C2 in patients without any apparent instability, and the results are not all that promising, at least in my hands. So for some reason, just 70% of them improved, and it was almost similar to results of simple posterior fossa decompression. So for me, I would prefer to do a posterior fossa decompression first. I'm not talking about those patients with assimilated arch of atlas and some so-called basilar invagination or vertical invagination. I'm not talking about those patients. I'm talking about simple the Chiari malformation type 1 without any apparent instability and normal C1 arch, and then we just fix C1 C2. For me, that is an overkill. We can always do a posterior fossa decompression first. If the patients for some reason do not improve, then we can give a trial of C1 C2 fixation, but that comes later on. And probably as Professor Klekamp had shown some Chinese paper about the OC1 instability. I had actually reviewed that paper, and possibly it is like, there could be something else. And I personally feel that we are missing something. It definitely is not instability. It is just fixing C1, C2 in all cases, to me, appears to be an overkill. So I would prefer to do a posterior fossa decompression first, and later on, if there's no improvement, maybe give a trial of C1, C2 fixation. And if even that fails, I don't know what to do.
Okay, brilliant. Dr. Yunus Aydin has suggested that absence of gag reflex could have a role in indication of surgery. So, George, what do you think about that?
Well, if there's evidence of cranial caudal cranial nerve deficits, this usually indicates medullary compression of the brainstem. And in most instances, it's a compression from anterior. So if I see a patient with Chiari presenting with problems of swallowing, then my suspicion is that this patient has instability in the craniocervical junction, and I will check that very, very carefully. Similarly, I will react if somebody is presenting with problems of ocular movements, such as nystagmus with gaze. That's also an indicator that something may be wrong with craniocervical stability. So these are clinical signs pointing you towards looking at this area more closely and analyzing carefully the anatomy of the joints in this region.
Okay, good. There's another question is how much decompression is required? Like, is there any standard and what is really the goal of decompression? Jan Jose, would you like to take that question, please? How much decompression is required? How much do you do?
The decompression
Yeah.
should not be very big. A craniectomy of almost not more than 2 centimeters and a resection of the posterior arc of the atlas. And I always do duroplasty.
Oscar, what's your take on that? Sorry, please unmute.
You know, as I said before, we tend to be a little bit more generous on bone work, and we go laterally almost to the condyles and in the arch of C1 as much as the vertebral artery sits. And we always try to have CSF flowing laterally, not only posterior. And that's the cases that have been reoperated. It was due to insufficient osteoligamentar decompression. And it's not only bone. You always see a lot of fibrosis, a lot of duplication of dura, of ligaments, and all this needs to be really, really thinned. Almost leave just the inner layer of the dura. And with the pulsatility of CSF, this will expand eventually.
Okay.
Mehmet?
One point that actually we don't have a pediatric neurosurgeon with us. So then probably the pediatric patients can be differently managed. Just bony decompression or dural ligament cutting will be enough in some patients, in the pediatric patients. Another thing is previously we were telling that complex Chiari cases should better have duroplasty, but however, simple Chiari patients may have more bony decompression or dural band resections. What do you think about this? I wanted to know the ideas of Dr. Klekamp as well.
Well, this is an ongoing discussion for quite a while, whether bony decompression is sufficient for Chiari 1. The problem is that, at least in adults, the dura will not expand if you just decompress by taking away some bone. So in adults, it's quite clearly that you should open the dura and do a duroplasty in order to get a proper decompression. In children, you may get away with bony decompression alone. However, you have to accept that the number of patients who will require a second operation because of insufficient decompression will be higher if you just do a bony decompression and if you do not do a duroplasty. So if you want to avoid any recurrence, any necessity to reoperate on these patients, then you should do a duroplasty in children as well. But that's my view and the view of quite a lot of colleagues I know. But I do know that pediatric neurosurgeons, to some degree, disagree with this point of view.
And what about arachnoid layer dissection? Would you dissect or would you just do extensile neuroplasty?
I personally open the arachnoid. I personally look into the fourth ventricle, whether it's obstructed or not. If it is obstructed, I open it. And the number of patients that have an obstruction of the foramen of Magendie is not so low. It's in the vicinity of 20 to 30% of all Chiari 1 patients. So it's not something that I would simply leave aside. So I personally do that. I have no morbidity associated with this arachnoid dissection, and the results have been very, very favorable, as I outlined already. And we also did a study on the histological findings. We gave the arachnoid we resected for pathological examination, and we found evidence of fibrosis and evidence of vascular proliferation in some of these specimens. And even the amount of arachnoid fibrosis did correlate with certain neurological symptoms the patients presented with, and with the likelihood of an associated syringomyelia. So there are indications, no proofs, but some indications that the arachnoid actually does play a role in the pathophysiology of these patients. And that's the reason why I do the arachnoid dissection in my patients.
Yeah, when we did the WFNS consensus meetings, we came up with this, that the overall consensus was that decompressing only without arachnoid dissection had same results as neuroplasty, and also going into the arachnoid itself, except for when patients had arachnoid dissection, there were higher complications compared to the ones in which arachnoid dissection wasn't done. So that was the consensus state, one of the consensus statements from the WFNS meetings. But surely there are different types of patients and different problems. Every patient should be taken as an individual. Any other comments, please? Mahmoud, would you like to wrap it up, please?
I think we discussed it enough. Maybe I want to give a few words to Dr. Yunus Aydın, who is with us. He's a valuable faculty from Turkey. Would you like to say something, Dr. Aydın?
Sure. Sure. Thank you. Actually, my question is about the size of the decompression. Decompression size is very important. If you look at the preoperative MRI, check the subarachnoid space retrocerebellar area. That shows the size of the decompression. We need to decompress the posterior part of the cerebellum to open the CSF pathways. And also, I routinely do duroplasty. The CSF leak after surgery might be this first sign of the maybe improper closure of the dural. But the second and frequent one, the inefficient decompression, and still going on some stress and increased CSF pressure and causes CSF leak. I do a lot of reoperation for inefficient decompression.
Thank you.
So, thank you.
Okay. It was a great talk. I thank all the speakers and all the moderators. And I think we will meet again on this Wednesday. Professor Al-Mefti will be the presenter, giving a conference to all of us. And I invite all the participants to our future meetings. I think we can finish it here.
Thank you, everybody.
Thank you.
Okay, bye-bye. Cheers. See you later.
Bye-bye.
Thank you very
Bye.
much. Bye.